This is the case of a 60-year-old male who presented with persistently high blood pressure that could not be controlled despite taking multiple medicines. CT angiography revealed a type B aortic dissection. Over time, long-standing high blood pressure, smoking, and aging weaken the wall of the aorta. When a tear develops in the inner layer, blood enters between the layers of the vessel wall. This causes the wall to split, disturbs normal blood flow, and results in a condition known as aortic dissection. In this patient, the type B dissection began just distal to the left subclavian artery and extended down to the infrarenal part of the aorta. This led to reduced blood flow to the renal arteries, causing persistent high blood pressure that could not be controlled with medicines alone. The patient also had complex aortic arch anatomy, making a routine stent graft unsuitable because bird beaking can occur when the stent does not fit the curved aorta properly and leaves a gap. There were three possible ways to plan this procedure. The first option was a hybrid surgical and endovascular approach. This would have required open surgery along with bypass for aortic arch vessels, involved longer recovery time, and carried a higher risk of mortality. The second option was a custom-made graft. However, this would have taken nearly 4 weeks for delivery, which was not suitable given the patient's condition. The third option was an on-table modification of a thoracic stent graft. An on-table modification was chosen as it was the safest and most practical option in this case. It also reduced the risk of bird beaking of the stent and allowed precise alignment with the arch vessels. A physician-modified thoracic endovascular technique was planned to seal the tear, reopen the true channel of the aorta, and preserve blood flow to the brain and upper limb vessels. The thoracic stent graft was modified on the table. A 15 by 15 mm opening was created for the innominate artery, and an 8 by 8 mm opening was made for the left subclavian artery, ensuring continuous blood flow to these vessels. The graft was then carefully reloaded. Vascular access was obtained through the right common femoral artery using a small surgical opening, along with access from the left arm via the brachial artery. The stent graft was advanced over a stiff guide wire, and an aortogram was performed to confirm correct positioning. The graft was partially opened to expose the fenestration, which was accessed from the left arm. After securing access, the graft was fully deployed, and a balloon-mounted stent was placed in the left subclavian artery to prevent endoleak. Final angiography showed good graft position, restored blood flow through the true channel of the aorta, and preserved perfusion of the left subclavian artery. This case highlights how a weakened aortic wall can lead to dissection and how physician-modified endovascular repair can safely restore circulation, protect vital vessels, and improve outcomes in patients with complex anatomy.